Welcome to Bad to the Bones, the podcast where we discuss everything related to orthopedics, joint health, and living an active lifestyle. Welcome to Bad to the Bones. I'm your host, Debbie Rody. Today, we're diving deep into one of the most common and life-changing orthopedic surgeries performed today, total knee replacement, also known as TKA. Joining me today are two guests from Premier Orthopedic Associates. We have Dr. John Catalano, who is a board-certified orthopedic surgeon, fellowship-trained trauma surgery. Dr. Catalano specializes in orthopedic trauma and fracture surgery, arthritis care, and total joint replacement. As an orthopedic trauma surgeon, Dr. Catalano performs surgery on high-impact bone fractures, such as those caused by car accidents, as well as industrial and work-related accidents. And joining us alongside of him is Danielle Francis. She works closely with Dr. Catalano's patients, and she is one of our experienced and compassionate physician assistants for over 15 years experience in emergency orthopedic care, conservative osteoarthritis management, and pre- and post-op care. So we're really excited to have both of them on the show today. Welcome, Dr. Catalano and Danielle.
Thank you.
Nice to have you. Total knee replacement is a huge category that we've been wanting to touch on. It's one of those surgeries where, as people are aging, I find even in my age group, in the 50s, people are getting knee replacements. And we want to talk a little bit about the distinction between a total knee replacement and just what it's like pre and post-op and what gets someone to that point. So let's start at the beginning, Dr. Catalano, if you can tell us a little bit about what is a total knee replacement and who is a candidate?
Right. Well, total knee replacement is more common now than it's been because the baby boomers are aging.
Yeah.
And being part of that group, it's the wear and tear of what we've done in our younger years starting to catch up with us.
Yeah.
So what a total knee replacement is, the last of a progression of treatment options for arthritis of the knee. The knee replacement surgery is a reconstructive procedure where we resurface the knee, realign the normal alignment of the knee, and get people back doing the things that they want to do and have to do.
Okay. Is it something that people are living with for a long time before they get to this point?
It's interesting you say that, because a lot of people will delay coming to an orthopedic surgeon for their first total knee.
Yeah.
And then once they've had the experience of a good result with that knee, they'll not wait as long with the second knee.
What are some of the conservative treatments that you might try before surgery, and how do you know when it's run its course?
Well, we always try conservative treatment first.
Yeah.
I mean, the true indication for total knee replacement in 2025 is the failure of non-operative treatment to allow people to return to the function level that they need to do or want to do.
Yeah.
So we start with anti-inflammatory medications. We start with exercise. Sometimes we do bracing.
Okay.
The next step would be injections, whether the anti-inflammatory injection, like, quote, the old cortisone injection,
Yeah.
or the more new modern viscoelastic injection, or the lubricant injections.
Okay.
Some patients, the best predictor of the recovery of a patient after total knee replacement is how well they're doing beforehand.
Right.
So sometimes we put people in prehab, which is it's pre-rehab or pre-physical therapy, like the analogy of spring training for baseball, getting them ready for their replacement.
And is PRP a part of that treatment? I know that's kind of new.
It's
came
new.
to my mind.
It's interesting.
Yeah.
I think the biologics are going to be one of those things that in the future will have a bigger role. But right now, I still think it's in its infancy. Okay. Despite what you hear in the media sometimes.
Yeah, because I just feel like patients are probably hearing that in the media, and what if they come in and ask for it? Is that a thing? And what are some factors that might rule out a patient qualifying for that type of surgery?
So we're looking at the age of a patient.
Yeah.
60's kind of the magical age range for us. But we're also looking at medical history. So if someone has uncontrolled diabetes or hypertension, we definitely need to get that medically optimized before proceeding with surgery.
Okay.
If a patient has dementia or vascular disease, that may rule out surgical interventions altogether. And everybody's age is different. So advanced
Yeah.
age could mean somebody that's 90 or it could mean somebody that's 75 with these medical conditions. So we have to really customize it for the patient on whether or not they're a candidate or not. We have to look at their medical history, how much they're up and moving around, their age, all of those things are taken into
It
consideration.
seems very thorough.
The biggest thing that the insurance companies are looking at is body mass
BMI.
index,
Yeah.
your BMI. So anybody over 40 is considered high risk for surgery because that can increase your risk of infection, blood clots.
Okay. And once someone does opt for surgery and they are a candidate, about how long does it take for them to get the surgery?
So once you
surgery
decide that you're going to have surgery, it's usually about 4 to 6 weeks.
Okay.
So to do all of the things that you need to do to get set up for surgery, about 4 to 6 weeks.
And in that time frame, is it safe to assume that they have to discontinue all of the anti-inflammatories and all the conservative options that you've been doing?
So we don't do any anti-inflammatory injections within 6 weeks of surgery.
Okay.
Medication-wise, we usually hold off on any anti-inflammatories for about 5 days prior.
Okay.
So you do have the option of continuing your medications by mouth up until about a week before surgery.
Okay. And Dr. Catalano, where does this surgery take place?
Well, my practice is my surgical practice for total knees is in Spira, Elmer.
Okay.
And I've been practicing there now for 30 years. I've been on staff.
Yeah, that's awesome. And do you use prosthesis at all? And if so, which
the
ones?
prosthesis that I use is the Zimmer product. It's either the next gen, which is the evolution of the IB2 knee, which is was the precursor of all the total knees.
Yeah.
Or the Persona, which is the third of the progression of the product.
I mean, as I ask that question, I'm thinking to myself, do you have patients that come in and actually have done their research on what goes into their body and prefer something, or say, I might be, I don't want that product in my body?
Well, if they do, then if it doesn't match my prosthesis, they're going to go to somebody else.
Yeah.
For me, I've been using the same prosthesis for 30 years. I know it inside and out, upside down, every variation.
That's important.
And all. And so, if you choose me as your surgeon, and I'll give people their options with some of the stuff within the Zimmer product. But I use the Zimmer product exclusively.
Okay. And let's talk a little bit about traditional versus robotic.
Sure.
What would be the key differences? Because everybody hears a lot about the robotic surgery and they're thinking it's just, some crazy little robot and there's no hands involved.
No.
What do we have here? What is that?
Well, I do exclusively the traditional total knee. I don't utilize the robot, although I did all the courses and I did the cadaver lab and I did it. Understand that all the data points that guide the computer were scanned off of preoperative and postoperative x-rays of people who did it the traditional way. Mm-hmm. That's number one. Number two, I'm not a person who's going to sit here and say it's not the right way or not, because I wasn't trained on it. I didn't do a fellowship with robotics because it wasn't available when I was training. But it's the analogy I have is that, some cars will parallel park themselves if you allow them to.
Yeah.
Most people will know how to parallel park their car manually.
Yeah.
So technology is a wonderful thing, utilized correctly. So if you look at the data points and you look at the results of robotic total knee replacement versus traditional total knee, and there's a great study out there of one surgeon who did close to 5,000 total knees on a prospective randomized study. The only differences were OR time was longer in the robotics. Mm-hmm. The cost was higher on the robotics, and the end result was no significant difference clinically. So maybe that's a little biased because I don't use it, but again, I'm not a dinosaur. I would change if I thought what was out new was
but it's kind of
better.
like, why reinvent the wheel if what you're
Correct.
doing is working, right? And your patients are having success. Danielle, let's talk a little bit more about, you touched on some of the pre-op process stuff. So once a patient and all of the outside physicians and such, who gives the green light for this patient to have surgery to make sure that their health is in optimal, condition?
So when you decide to have a knee replacement, we want to make sure you're medically optimized. So
Yeah.
we're going to send you to your family doctor
Yeah.
for an evaluation. You're going to get some lab work done. Generally, we do an EKG and a chest x-ray. We're looking to make sure that you are at top optimal health.
Yeah.
So your family doctor is going to provide a medical clearance for us, letting us know that you are, in fact, a candidate for surgery.
Mm-hmm.
If they find something abnormal in the labs, they may send you for further clearance.
Mm-hmm.
A lot of times patients will go to see the cardiologist. You may need a stress test. All of those things are done in those 4 to 6 weeks that we're talking about prior to surgery.
Yeah.
We also need you to see your dentist. It's very important that any dental work is done before surgery because when we get your teeth cleaned, bacteria gets into the bloodstream. And metal and plastic in a total joint replacement doesn't fight infection like normal bone.
Yeah.
So we want to make sure that anything that needs to be done is done ahead of time. So that is a potential thing that may delay your surgery.
I didn't know about the dental.
The biggest
part.
thing is dental work.
Yeah. I mean, do people ever like really fight you on this whole procedure? Like, oh my gosh, do I really have to go there and go there and get this done?
Absolutely.
Yeah.
But, knowledge is power. So when you explain why it's important, usually everyone falls in line.
Yeah.
And that's something that we take very seriously. After surgery, we use antibiotics for any dental work, any cleanings, any cavity fills, anything done, we require dental prophylaxis. And we do that forever because we don't want to give you a nice knee and then have you get an infection 10 years down the road that requires you to go back in for surgery. So that minor inconvenience.
It's an ounce of prevention worth 20 pounds of cure.
Absolutely.
Oh, yeah. And
What I sell to my patients with is saying, okay, you're going to get in the car and you're going to put your seatbelt on.
Right.
Do you need it every time? Nope. But when you need it, you need it.
Yeah.
Absolutely.
Yeah.
So the same thing, you go to the dentist, take the pills, get your teeth clean, and you don't have to worry about it.
You have some good analogies, Dr. Catalano.
Years of experience.
So, Dr. Catalano, let's talk about the weeks leading up to surgery, besides all of the medical visits and such that patients need. What about preparing their home? I mean, some people might not even think, they probably feel like I'm just going to, come home after my procedure and lie on the couch or lie around and just work around my house, do what I need to do.
Yeah, getting your life together, getting your house together is an important thing, and your yard. I mean, if you're out there cutting your grass and you're getting your total knee done in the summertime, you might want to hire a neighborhood kid or a landscape company to cut your grass for the first month after your surgery. But we try to again, an ounce of prevention is worth 100 pounds of cure. Throw rugs, doormats, extension cords. Magazine racks that are in the way, on the clear. I tell patients, walk through your house, scraping your feet. Know where the transition is between the rug and the tile or the linoleum and the hardwood. Tripping precautions. The number one place is in the bathroom. Is the
the threshold and stuff.
Well, but also that U-shaped rug that's.
Oh, around the toilet?
My older population tends to have around the toilet and the bath mat.
Yeah.
Get rid of them.
Yeah.
Throw pillows. Get rid of them. Throw them away. They're just going to cause a problem.
I have a ton of those.
Right. But they can go in the closet until you recover from your replacement.
Yeah.
So that's important. Normal monthly type things like putting solar salt in your water conditioning system.
Right, like kind of stay ahead of household chores and stuff.
Put 2 bags in front instead of one.
Yeah.
And just they're little things, and we talk about these, in the thing. Now, preparing for meals. Get some stuff in the freezer.
Yeah.
You may not be able to go grocery shopping. So if your significant other isn't good in the kitchen, meaning the male, the wife needs to do some stuff to lead up to that.
Yeah.
But, we go through these on a case-by-case basis. If the only bathroom in your house upstairs, then we have to worry about, is there a powder room downstairs? How many steps?
So are patients not able to do steps?
Oh, no,
or you encourage them to do that?
Usually our patients can do steps probably within a couple of days.
Okay.
So, the rule is once you're up, you're up. Once you're down, you're down. But there's also accommodations that we can make with hospital beds and commodes and things like that.
Okay.
Again, not everybody gets everything.
Yeah.
This is a case-by-case basis.
Yeah. And Danielle, there's People should also avoid alcohol as well, right? I mean, leading up to surgery, or could I have a glass of wine the night before because I'm stressed?
So we try and avoid alcohol a couple days before surgery because it is technically a blood thinner.
Yeah.
So all of our supplements that could cause bleeding, we stop about 5 days prior.
Okay.
And then we also want to avoid other things like THC or CBD oil, which
Any
could also
other party
affect,
drugs, party favors?
right, affect your
Scooby
ability to have
snacks.
surgery. Yes.
Okay. And is it possible for an individual to obtain a handicap permit, like a temporary, for when they are able to, like, for example, if I had my left knee done, I can still drive with my right foot, maybe, or no?
After 2 weeks.
Okay.
So our rules are that, number one, you can't be on big pain medication and behind the wheel.
Oh, yeah. Makes sense.
That's common
Yeah.
sense.
Yeah. Yeah.
But the normal rules is nobody drives in the first 2 weeks.
Yeah.
All right. We want you at home doing your exercises, not exposed to the community. We don't want you to get sick. And we learned this during the pandemic. We don't want people, going out getting COVID, then they can't go to physical therapy.
Right.
No physical therapist is going to come to their house.
Yeah.
We don't want you in the office, kind of thing. But so the first 2 weeks you're basically at home. If you're doing really well, we'll let the left total knee patient drive right after our first post-operative visit.
Yeah.
The right knee, usually 3 to 4 weeks, depending because of reaction time. And
Yeah.
don't tell me you're going to drive left-footed because you've been driving
Oh my gosh,
for
that's
40
or
years.
2 feet,
Right.
one for
yeah,
the.
don't know. I'm not
Yeah.
going to listen to that.
No,
but,
thanks.
But just the norms are after the first visit for the left knee and maybe a week or so later for the right knee.
Okay. Let's talk about the day of surgery. Dr. Catalano, what is a typical when a patient arrives? How does that process go?
Go ahead, Danielle. You can.
So from the day that you sign up for surgery, we have you meet with a surgical coordinator. We want to make sure that we know your whole medical history, any allergies that you have, medications that you take, supplements that you take, because our plan is tailored to those medications, and we want to make sure that we keep you completely safe.
Mm-hmm.
So it's important to know certain allergies, like do you have a metal allergy to nickel, because what we're going to put in has nickel in it.
Yeah.
So these are questions that we ask prior to even setting you up for surgery.
And if someone says, I don't know if I have a metal allergy, I mean, is that something that they now need to go get tested for?
Yeah, and there is a test for that.
Okay.
Mm-hmm.
Yeah. But usually people know, like, I can't wear fake jewelry or I get a reaction. And then it's something that is discussed for every total joint patient.
Yeah.
And then we also, a week before surgery or 2 weeks before surgery, you'll meet at the hospital with the PAT nurse that's going to go over all, again, your medications, your allergies, your medical history, so that we make sure that everything is, again, safe for surgery.
Yeah.
With that appointment, there's a couple tips that I have for that. You are going to get some lab work done, and it is fasting. So usually you're not going to have anything after midnight the night before to eat or drink.
Okay.
If your appointment's in the afternoon, we usually say light breakfast and try not to eat anything for 6 hours.
Okay.
You will need to provide a urine sample, so we want to make sure that you have the ability to do that for us. Most people will bring all of their medications, everything in the cabinet that you could possibly take, because we want to go through each individually with the nurse and make sure that, we're telling you what you can take and what you have to stop.
Okay.
We're also going to give you some wipes to take and use the night before surgery. So these wipes are antimicrobial. We know there's a risk of infection anytime we make an incision. So we do a whole body cleanse other than your face and private parts. And that is done after your shower. Some people are allergic to them.
Okay.
And if you get a rash, we don't want you to use your second wipes in the morning, and we do want you to take a shower because we don't want you to come in with a huge rash all over your body.
Yeah.
But if we can use them, that does help to prevent infection.
Okay.
So those are a couple of the things that the nurses wanted us to go over that are, very important with making your PAT appointment successful and preventing any cancellation of surgery in that way.
So what is this CMP, the day before or the day of surgery?
So the
CPM,
CPM machine
sorry, yes.
is a continuous passive motion machine that'll get delivered to you. So either the day before surgery or the day after surgery, but usually you're contacted by the medical provider ahead of time and you know when it's coming.
Okay.
We use that to bend your knee so that you don't have any issues with flexion after surgery.
Okay. And everyone who's getting a total knee replacement gets that?
No.
For Dr. Catalano's
For me,
patients.
yes.
Oh, okay.
So it's been a real change in the use of CPM machines over the last probably 5 to 6 years. A lot of people don't use them anymore. That increases patients' need for outpatient physical therapy.
Okay.
It increases the need for a manipulation. So I've been very adamant about maintaining the CPM machines. We have a program through Premier where we are able to provide CPM machines to our patients,
Yeah.
and we use them for 3 weeks after surgery.
Okay.
And it's 6 hours a day, 2 hours in the morning, 2 hours in the afternoon, an hour or so at night, and our patients are much ahead of other patients at the 2-week mark and 4-week mark. In fact, I have patients that come to me now because I use a CPM machine because
Yeah.
they've been in therapy with other patients who have had that I've done with a CPM machine, and they didn't get it with their first knee.
That's interesting. Tell me a little bit about what does the machine look like? What does it do? Is it like just strapped onto your knee? And
Right, so your leg sits on it.
Okay.
It's a base plate that has a cradle for your leg,
Okay.
and then there's a control where you increase the speed or increase the degrees that it bends. So we start you the day of surgery at 0 to 60 degrees, increasing 10 degrees a day, and up to about 110.
And it's manually moving your leg?
Yes.
Oh, that's awesome.
It's
Which
free.
you wouldn't
It's
do.
free exercise.
Yeah,
It's
yeah.
absolutely free exercise. You lay there, you read a book, you watch TV,
Yeah.
you sit on your Kindle, and you let the machine do the work.
That's fantastic.
You know, it's
Yeah.
not a torture machine, and like I said, more people than not will comment afterwards like, "I'm so glad I had that machine because
That's
when I went
great.
to therapy, I was very far ahead of the other
Yeah.
patients."
Well, it sounds like, I mean, obviously I'm not a physician, but it's increasing blood flow to the injury, right?
Correct,
Maybe?
and blood return.
Yeah.
So the more your leg moves, and the less it's stiff, the less chance of blood clots too.
Wow. That's interesting. That's good stuff.